I'm Sumaira. I'm a community oncologist. I wanted to give a little update on a lot happened in 2025 in the world of metastatic breast cancer. I have no disclosures to really, I have no disclosures. So apparently, let's first talk about the triple negative metastatic breast cancer. Since Keynote 522 came, we were very excited about use of Keytruda in the world of triple negative breast cancer. It eventually came right away in combination with immunotherapy in the world of advanced metastatic triple negative breast cancer. And we have been using it for a good bit of a time with good PFS, good disease response curves. We did have a new drug called sacituzumab, more in bottom line settings in the past, but in 2025 through a CENT4 Keynote D19 study, sacituzumab with Keytruda, it was compared to conventional chemo with Keytruda in previously treatment naive PD-1 positive metastatic triple negative breast cancer. So I'm going to quickly go over a little bit on the basics of how the study was designed. People who were PD-1 positive, greater than 10% were enrolled in the study, greater than 6 months since last treatment in the curative setting. Even prior use of PD-1 was allowed, but we're going to look into the data, how it kind of looked like. There was a 1-to-1 randomization, and the primary endpoint was the PFS. There were secondary endpoints like OS, ORR that we're going to quickly review in a second. Very important here to look at the baseline demographics. I don't think it kind of pinpoints, but we are pretty much looking at the de novo versus recurrent within 6 to 12 months or recurrent greater than 12 months. And we can see how the kind of shift of, the spectrum of the baseline characteristics kind of range for the patients who have had previous treatments and they have recurred over 12 months of time and they have gotten enrolled into the clinical trial. Pretty much metastatic disease to all other sites were, all the sites were included in the study. And this is a great PFS curve, in my opinion, for a triple negative disease. If you look at the right side of the table, the median PFS in the sacituzumab plus Keytruda arm was 11.2 versus 7.8 in the conventional chemo plus pembro. For triple negative, it is statistically and in my opinion, a clinically meaningful change. So definitely a big change in terms of PFS. Pretty much a subgroup analysis, and if you look at that, pretty much all the arms kind of in this forest plot are favoring the site of sacituzumab plus pembrolizumab. So pretty much all comers, except for the people who had previously gotten PD-1, which did not achieve a statistical significance. So it's a little area of gray zone to use it in those people, but otherwise pretty much everybody benefited from use of sacituzumab plus Keytruda. Overall survival is not mature yet. There is a slide that I had accidentally missed, but I would like to go over it. So there is a good bit of an overall response rate and the duration of response. So in terms of duration of response from the sacituzumab plus Keytruda, it was 16.9 months versus around 9 months as compared to the conventional chemo arm. And I personally think it did achieve statistical significance and again, clinical significance in my opinion in the setting of advanced breast cancer. It did have a good bit of a CR percentage as well. If I remember, I think it was 13 versus 8 months. 13% was the sacituzumab plus Keytruda arm. And then, more importantly, when we are treating advanced triple negative breast cancer, I think most of us are trying to achieve a stability of the disease and not let the disease progress. The progression was more in the chemo plus Keytruda arm. That was around 12% versus 8% in the setting of sacituzumab plus Keytruda arm. So these are a good bit of differences. I think the safety summary, no unusual side effects were seen, just for the sake of time. Very important perspective here that I would like to pinpoint is pretty much like treatment-related dose reductions. If you look here, the chemo, often we have to kind of dose reduce in terms of toxicity profile. With sacituzumab, it was relatively lower. So that's another good kind of a percentage, in my opinion, to keep your patients at a good doses and not requiring a dose reduction. So pretty much safer, good safety profile. No unusual side effects were seen. There is certainly issues with cytopenias, diarrhea. There is some issues with altered LFTs. Pretty much all the expected side effects, no unusual side effects were seen in either of the group, but certainly in the sacituzumab group, which was our targeted group in this population. So to conclude, pretty much it is one of the NCCN newly made kind of newly made into NCCN drug called sacituzumab plus Keytruda, which is now upfront in the use of PD-L1 positive patients who are BRCA negative. Even if they are PD-1 negative, we do have an option of using sacituzumab alone. And if patients have not seen them, this could be a good second line. But certainly if you have a good viable patient, I would probably use sacituzumab plus Keytruda as a first line. Another change happened in the HER2 positive metastatic breast cancer. I was thinking Dr. Sarfaraz is going to be talking before me, so she's going to bring that up. But we have been all talking about Enhertu, called TDX2, in the adjuvant setting. But this trial is basically Destiny Breast 09, which is for advanced metastatic HER2 positive breast cancer with a disease-free interval of greater than 6 months from the last chemo or any HER2-based treatment, which could be even in the neoadjuvant or adjuvant setting. So in my opinion, it's a great trial for our patients because most of our HER2 positive patients would actually be getting a chemo and a HER2-based treatment upfront. And then eventually, if they are progressing to metastatic disease, this could be a great trial to implicate on them. The primary endpoint is pretty much the PFS. And we are looking at this PFS where we are looking at in the study arm with Enhertu plus pertuzumab versus the standard of care THP, 40.7 versus 26.9 months. So definitely around 13.8 month difference in terms of PFS, which is a great outcome in patients with advanced HER2 positive breast cancer. Overall response rate in terms of CR was 15.1 versus 8.5 months, and the response rates were pretty much durable in terms of median duration of response between 39.2 and 26.4 months. Treatment-related side effects pretty much controlled. Nothing unusual was seen. We had used Enhertu in the kind of more third-line, second-line settings in the past. No unusual side effects were seen. So to conclude, again, 2025, as I said, was a great year in the world of metastatic breast cancer. It did make up to the NCCN as a first-line treatment for metastatic breast cancer. So we have a now new regimen with Enhertu plus pertuzumab as the first-line treatment as compared to the THP, which we had been using probably since I was even a fellow. So a very revolutionary change. Hormone receptor positive, HER2 advanced breast cancer, HER2 negative advanced breast cancer, we do have good treatment options available. We all have been using endocrine therapy plus CDK4/6 inhibitor. Great responses. We are very happy with it. So it's not one of the tumors where I worry a lot when I have a patient. However, there was an Innova 120 trial there. It's pretty much from last year as well, presented at ASCO, where they had used first-line inavolisib with placebo versus placebo with palbociclib plus fulvestrant in patients with PIK3 mutated. So again, something you are checking NGS. We were just talking about it a few moments ago. There's more like a PIK3CA mutated directed therapy that you are using here. These patients could have relapsed during or within the 12 months of adjuvant endocrine therapy completion. So again, something as a standard of care that we implicate. Most of our patients are on the endocrine therapy, and most of them would relapse in that setting. Pretty much that's an assignment of 1:1 randomization where they have used inavolisib plus palbociclib plus fulvestrant versus just the standard of care. So this is the primary PFS result here. We could see a good bit of a difference in terms of the PFS outcome, 15 months in the study arm versus 7.3 months in terms of the standard of care arm. This is important curve to me because that makes a difference to what would be the next line of treatment. When patients are usually progressing after the use of CDK4/6 and endocrine therapy, we are typically talking either about chemotherapy or not very effective treatments like everolimus. The time to the time to the switch to different line of treatment in terms of the study arm and the comparison arm was 24 months versus 15.1 months. It did achieve the statistical significance with a difference of around 8.9 months. So pretty much good bit of a safety profile. We had been using PIK3CA inhibitors in the second line, third line settings. No other side effects were noted. Pretty much hyperglycemia, diarrhea, rash, and the mouth sores were the concerns. I think we primarily try to target our patients with a hemoglobin A1Cs above 6.5 away from PIK3CA inhibitors. In this case, certainly that was one of the inclusion criteria included. So hyperglycemia was noted as one of the main side effects coming up. It did require a little bit of the treatment interruption, some dose reductions, but not a significant discontinuation. We have great endocrinologists to help us out here. So conclusion and implications here, very important. Do I use the combo? All my patients with PIK3CA mutation and kind of have nothing for their future? That's a very important implication to me, because I'm not practicing in one of the, like a breast center kind of a thing. I'm a community oncologist. To me, it makes a whole lot of difference. I want to kind of work for today, but also reserve something for future. So for me, if I have a patient with a low volume disease, kind of a borderline PS, still not kind of ready to accept all the treatments, I still stick with my old conventional CDK4/6 plus endocrine therapy. But I have a patient with a high volume of a disease where I was worried, maybe I'm going to use chemotherapy. I would probably go with this combo. So pretty much this is the conclusion on this slide. And I don't know if you guys watch Spider-Man movies. I do. So at the end of every Spider-Man movie, they give you a glimpse of their future movie. This is San Antonio Breast Symposium from December, which is going to show up on the ASCO definitely next year. We were just talking about the dynamic mutations on the last presentation. This is EMBER-3 phase 3 trial design, where they are using either in the patients in adjuvant setting, where they had recurrence on already endocrine therapy for around 12 months of completion with a combination of CDK4/6, or in the advanced setting, they are progressing on the first line while they are using AI plus CDK4/6. They have used a medication called SERD. I don't know if you have heard about it. It's a selective estrogen receptor degradation product. It's called imlunestrant. It's kind of a family of ESR mutated drugs. So apparently, they are comparing either a single agent versus standard of care versus combining this SERD with abemaciclib. Now, for the sake of the time, we're going to use at the primary. We're going to look at this primary endpoint of the PFS. Okay, so this was single agent imlunestrant versus standard of care in ESR mutated patient. We do see a PFS difference here. In all comers, there was not statistical significance, but I want you to take a look at this curve. In all patients, irrespective of their ESR mutation status, combination of imlunestrant plus abemaciclib versus imlunestrant did give enough of median PFS of around 9.4 versus 5.5 months. And it's irrespective of their ESR mutation status. So I do have a couple of patients here that would be on CDK4/6 and endocrine therapy, and they are progressing. And over the passage of time, we all run their ESR mutations. If they come out to be ESR positive, or even if they don't come out to be an ESR positive, but we are worried about the estrogen receptor, aromatase inhibitor resistance pattern, we could use these SERDs as our additional factor, additional drug on top of CDK4/6 and endocrine therapy. So this pretty much concludes my talk. Thank you.